There are actually a whole lot of things that come into play when we're trying to make a decision between the existing therapies that exist when we have a patient who is sitting in front of us. And it's becoming increasingly more important to use something called shared decision making or personalized treatment choices with our patients, because there are just so many different therapies that are available. So when we are trying to decide on one disease modifying therapy versus another, we're looking at very important things like making sure that it's probably going to work the best for that particular individual, and it can be very difficult to predict if someone's going to respond to a particular therapy, but we have some indicators that might be able to give us an idea of whether or not they should be on a more highly effective therapy versus a lower effective therapy, depending upon the number of negative prognosticators they have. But we also want to look at tolerability. We want to make sure that our patients are going to be able to persist on a certain medication. We also want to make sure that we're looking at affordability, accessibility. We also want to take into account that our patients are younger and family planning might actually be something that's on the horizon. So, is this particular disease modifying therapy going to be appropriate if this patient wants to start family planning in the next year or two? So there are different facets that we want to make sure that we're taking into account when we are having these very important conversations with our patients at the bedside. In terms of clinical effectiveness and what might be the best outcomes, those are some of the most important questions that we have. So historically, we've used annualized relapse rates as our primary outcome measures for our pivotal phase 3 clinical trials that are looking at the efficacy of a certain drug versus either placebo or an active comparator. But now, we're starting to develop more drugs that have a place for our progressive patients. So is an annualized relapse rate the best overall primary outcome measure for that particular patient population if they're no longer as inflammatory? So looking at other kinds of surrogate measures of disability, or the expanded disability status scale score, and looking at clinical definite progression or clinical definite improvement, and whether or not we can start using composite measures. So not just having one outcome, but having 3 different outcomes that are all part of a single measure. Is that something that we should start employing into our randomized control trials? So in terms of effectiveness, clinical effectiveness, those are some of the things that we can look at. But then there's increasing interest in MRI, radiographic disease activity, not necessarily just T2 lesion volume, which is essentially how much inflammation we have in the brain and the spinal cord, but looking at brain atrophy rates, especially when we're looking at a more progressive population of patients where brain atrophy is starting to become more prominent and is a measure of neurodegeneration. Patient-reported outcomes are also becoming crucial, especially when we are personalizing care at the bedside. So being able to implement these patient-reported outcomes, these questionnaires, into not only our randomized control trials, but our observational studies as well. So all of these things together, I think it's not really just necessarily one measure, but all of these things together that ultimately are going to be able to give us the best estimation of how a particular drug is working for a particular patient. And it's going to be very difficult to take generalized population-based data into an individualized case. But we do the best that we can based on making sure that we are representing the patient populations well in our study.